Thank you. Good morning. Thank you, Chairman Griffith. This hearing is an opportunity for us to evaluate recent trends and developments in the healthcare system that impact the 340B drug discount program. The 340B program was created by Congress to, quote, enable covered entities to stretch scarce federal resources to reach more eligible patients and provide more comprehensive services. It's a worthy goal and a seemingly straightforward one. For community health centers, high disproportionate share hospitals, and rural providers, savings from the 340B program are critical. In some cases, savings from the 340B program are helping keep the lights on at what may be the only hospital in a rural community. And those cases reflect the spirit and intent of the law to ensure essential services for our most vulnerable communities. With that said, I worry that the program is being co-opted by larger, more profitable healthcare systems that are using it solely for financial gain at the expense of the patients that need it most. We've talked a lot in this committee about addressing the impacts that high healthcare costs have on patients, employers, and taxpayers, and how we need to work to create a simpler and more transparent healthcare system. Every single one of us pays for the high cost of healthcare, whether that's at the doctor's office, through our insurance premiums, or in taxes that cover the ever-increasing cost of Medicare and Medicaid. Something that's becoming increasingly clear is that the 340B program is distorting markets and behaviors in our healthcare systems that are creating cost for all of us. In multiple studies, researchers found that the 340B program was associated with a nearly 25% reduction in the prescribing biosimilars and other lower-cost drugs in favor of more expensive brand name alternatives, so that hospitals could pursue larger savings from the program, even though patients' out-of-pocket costs are not tied to any of the savings that the hospital may receive. Additionally, the New York Journal of Medicine found that the program further incentivizes hospital systems to acquire independent oncology practices so that they can expand their 340B footprint. Some will argue that hospitals reinvest these savings in ways consistent with the intent of the program. But there's little evidence to prove this. This committee has focused so much effort over the past 2 years on increasing transparency in healthcare, tackling incentives in the prescription drug market that push up healthcare costs for Americans, and addressing site neutrality and other reforms that are driving consolidation. It should be a bipartisan goal for every member on this committee to apply the same principles to the 340B program as well. Let me reaffirm once more that I support this program in its original intent and mission. Last year we heard from Pallone Regional Hospital in my district about the value that the 340B program provides to them and other hospitals. I visited them in Eastern Washington and across this country. We've also heard testimony in support of increased transparency for the program so that we can, at the very least, understand how covered entities are using this program. If we are serious about lowering healthcare costs for Americans, then we must take a critical look at the 340B program and make sure that it is achieving its intended mission. So I look forward to hearing from the witnesses today, and I yield back.
Gentlelady yields back and now recognize the ranking member of the full committee.